discuss today an extremely important condition, that is pulmonary embolism. So the learning objective of my talk are to discuss various presentations of pulmonary embolism, to discuss initial approach to diagnose a patient of pulmonary embolism, to discuss indication of initial treatment like thrombolysis, and to discuss the long-term anticoagulant treatment and its duration. The acute pulmonary embolism is an extremely common condition. It has a high mortality rate if you do not treat it appropriately. Clinical presentation is highly variable and non-specific. You may have mild symptoms to a very fatal where patient can die because of pulmonary embolism. Diagnosis requires appropriate and accurate imaging. Prompt diagnosis and treatment can reduce mortality from 30% to 2.8%. Pulmonary embolism is common in males than females, and the overall incidence is about 112 cases per 1 lakh, and it rises with age. In United States, who always have data for everything, they have noticed that almost 1 lakh people die because of pulmonary embolism in their country. You can classify pulmonary embolism in many ways. One of the classification could be that a patient has presented acutely, subacutely or chronically, and also on the basis of whether a person is hemodynamically stable or unstable. The third classification could be on the basis of the location, like whether it is a lobar, segmental or subsegmental. And also you can classify based on the symptom, whether a person has symptoms or not, symptomatic or asymptomatic. Whenever you have a patient of pulmonary embolism, the initial approach to management of this patient will depend on whether a patient is hemodynamically stable or unstable. You call it hemodynamically unstable when a person has a systolic blood pressure 90 millimeter of mercury for at least 15 minutes, or who is requiring vasopressor to maintain blood pressure, or a person who has a clear evidence of shock. You call it a hemodynamically unstable patient. Then there could be a patient who is hemodynamically stable and has a pulmonary embolism. Now the presentation of this could really vary. There could be a patient who has a very mild embolism and does not have any signs of right ventricular dysfunction, or there could be a patient who has acute pulmonary embolism without hypotension, but either has a right ventricle dysfunction or myocardial necrosis, or has both. You call it right ventricular dysfunction when a person has at least one of the following, like right ventricular dilatation, right ventricular systolic dysfunction, right ventricular dilatation on the CT, and there is elevation of the BNP more than 90 mics per ml, or there is a rise of pro-BNP more than 500 per ml. Similarly, there could be a change on the ECG or EKG, which is showing the right ventricular strain pattern. And you call it a myocardial necrosis when this patient has a rise of trop I and trop T. Either of them, if it is raised, you call it a myocardial necrosis. A person who has a right ventricular dysfunction and or myocardial necrosis, the terminology sometimes used is a submissive pulmonary embolism. The initial approach to a patient of suspected pulmonary embolism should focus on stabilizing the patient while you are doing clinical evaluation and doing definitive diagnostic testing to diagnose this patient. And also it is important to do the risk stratification, because it helps you to triage the patient and prognosticate the patient. So when a patient has presented to you with the diagnosis of pulmonary embolism, you should, the first and foremost is you should provide oxygen to maintain saturation at more than 90%. Quickly obtain a peripheral line if it is not there, and if patient has severe hypoxemia, hemodynamic collapse or respiratory failure, you can intubate and provide mechanical ventilation. Now it is important then when you intubate these patients are prone to hypotension. So an expert member should intubate, and at the same time you should be prepared to manage hypotension if it develops in that particular patient. And if the patient is hypotensive already or develops later, you should give fluid, and you should administer about 20 ml per kg or 500 ml to 1000 ml of isotonic crystalloid. You should not give more than this fluid because there is a limited data, but it has suggested that if you give aggressive fluid to these patients, it may be harmful to these patients. And the rationale for giving limited fluid to these patients is based on the preclinical studies and one human study which had shown that if you give a small volume of IV fluid to these patients, there is increase in cardiac output. But if you try to give more fluid to these patients, it can result, because there is an obstruction, this can result in a right ventricular stretching, and it can worsen the right ventricular ischemia and worsen the right ventricular failure and can worsen the hypotension further. So 500 ml to 1000 ml you should give to these patients, and beyond that you should not give an unmonitored fluid to these patients. So once you've given fluid, then the next thing is to give the vasopressor if the blood pressure is still low. And the choice of a vasopressor, norepinephrine, has been suggested as a good choice because it's a preferred agent, and they have seen that it increases systemic pressures and result in improved coronary perfusion and also improve the right ventricular functions. You can add dobutamine to these patients, but dobutamine can result in hypotension. So you should have a norepinephrine first. You can try adding dobutamine. If required, you can increase the dose of norepinephrine further. So when you are stabilizing the patient, at the same time you are taking a clinical history and doing examination. The symptoms and sign of a patient of pulmonary embolism, depending on the severity, it could be asymptomatic to mild dyspnea to a very severe dyspnea. So if a person has a life-threatening pulmonary embolism, he could have a profound dyspnea at rest, anxiety, lightheadedness. If you examine, there is a hypotension, tachycardia, tachypnea and cyanosis. He may have signs of distended neck veins, a parasternal heave, an accentuated P2 and tricuspid regurgitation. When a patient has all these, you suspect this could be a massive pulmonary embolism. Then the symptoms per se of pulmonary embolism, if you see all kinds of pulmonary embolism, dyspnea is the commonest symptoms. It was seen in a PIOPED study and this study also, and various other studies which have shown that dyspnea is the commonest symptom, followed by pleuritic chest pain, cough and substernal chest pain. Few patients can have fever, hemoptysis, syncope, unilateral leg pain. And then almost in this study 25% patient had a sign of DVT. So the commonest symptom in these patients remains the dyspnea, which could be dyspnea at rest is the commonest symptom. So when you are seeing or when you are taking a history, at the same time you should assess the risk factors in that patient. Does he have a risk factor which can predispose this patient to pulmonary embolism? Prior venous thromboembolism, immobility for more than 48 hours. A patient who had undergone an orthopedic surgery, he was doing all right and he's been immobilized for the last 4 to 5 days or 3 days. Patient having congestive heart failure, septic shock, surgery with general anesthesia. Patient is on a mechanical ventilator for a long time. Abdominal or lower extremity surgery or trauma. Patient has a hypercoagulable state. Patient has a malignancy, spinal cord injury, heparin-induced thrombocytopenia, pregnancy. Patient has an indwelling central venous catheter, obese patient, congestive heart failure, and patient had traveled long to a flight more than 13-14 hours from, let's say, from India to US. So I have seen few patients who developed DVT and followed by pulmonary embolism because they travel long distances. So once you have made up your mind that this person could have pulmonary embolism and you have the symptoms and you have assessed for the risk factor, now you have to make a assessment of the probability of pulmonary embolism. So how do you do that? It could be by clinical judgment, like a person who's very experienced, who's been practicing pulmonary medicine for last 20 years, 15 years or 10 years, and he has seen many patients of pulmonary embolism. By his clinical judgment, he could assess the probability of pulmonary embolism. Or to help, there are clinical decision rules or scores which can help you to make a diagnosis or probability of a pulmonary embolism in that patient. Like this is a Wells score, which has various components, and based on the score like 0 to 1, if you get the Wells score, it has a low probability, 2 to 6 intermediate probability, and if you get more than 7, you have a high probability of this patient having pulmonary embolism. Or you can have a 2-level score, pulmonary embolism likely or unlikely. If you have a score more than 4, it's a pulmonary embolism likely. So these can also help you to diagnose or suspect a patient that this patient has a pulmonary embolism. Similarly, there's another score called the Geneva score, but Wells score usually is considered better by most of the people. So these are the rules. So you have suspected, and you have now the probability of pulmonary embolism based on your clinical judgment or scores, and the commonest score used, I said, was the Wells score. And always remember, when you are taking a history of a patient in a pulmonary embolism, always take a history which include negative history to rule out the contraindication for thrombolysis. Because if you diagnose, then you have to think of thrombolysis. So history should also take into consideration this. Now you have diagnosed or you have suspected pulmonary embolism in your patient. You need to initiate treatment, because you need to give empirical anticoagulation to these patients pending the definitive diagnostic testing or to prove the diagnosis. So empirical anticoagulation in a suspected patient of pulmonary embolism will depend on your clinical suspicion of P. That means whether it is a high probability, intermediate probability, or a low probability. In a high probability, you would like to give the empiric anticoagulation as soon as possible. Or what is the risk of bleeding? If person has a risk of bleeding, you would not like to give empirical anticoagulation. But if person does not have a risk, you would like to give it. And how much time it is going to take to do a definitive diagnostic test? In a bigger hospital, it may not take much time. With a smaller nursing home, he has to go to a distance to get the test. If it is taking time, then probably you will give an empiric anticoagulation to this patient, even if it is an intermediate or a low probability. So what are the options? The options are subcutaneous low molecular weight heparin, fondaparinux, and intravenous unfractionated heparin. You could choose any one of them, but then it will depend on whether there is a presence or absence of hemodynamic stability, because in a hemodynamic unstable patient, there could be a possibility of thrombolysis, so you would like to give unfractionated heparin. The anticipated need for procedure for thrombolysis and the presence of risk factors and comorbidities. So these 3 factors, whether patient is hemodynamically stable or unstable, whether you are going to give thrombolysis, whether patient has any comorbidities which prevent particular type of anticoagulant. For example, low molecular weight heparin may be chosen for a patient who is a hemodynamically stable and does not have any renal insufficiency. Similarly, you could choose unfractionated heparin for hemodynamically unstable patient, because you are thinking this patient could require the thrombolysis or surgical embolectomy. Direct thrombin inhibitors and factor Xa inhibitors should not be used as a method to treat empirically in a hemodynamically unstable patient. So you should give them, the dose is enoxaparin 1 milligram per kg every 12 hours, tinzaparin, deltaparin, norepinephrine. Most of them are almost equally effective, and they can be given once a day or twice a day. Fondaparinux is given only once a day according to the weight of the person. Less than 50, you give 5 milligram, 50 to 100, you give 7.5, and more than 100, you give a 10 milligram of fondaparinux as a single dose when the patient is undergoing the diagnostic test to diagnose pulmonary embolism. In patient who is hypotensive, in those patients, you would choose unfractionated heparin. And the dose which is recommended is that you give 80 units per kg as a bolus to these patients, and then you can start 80 units per kg as infusion. And there are nomograms available, and you maintain the APTT between 1.5 to 2.5 in these patients. Then you should adjust the dose if patient has a renal failure, patient is obese, pregnancy, and thrombophilia of the low molecular weight heparins. Then there are certain conditions where you accept the risk of bleeding, like a menstruating female who's got a pulmonary embolism, you will still give the heparins. A patient who's got an epistaxis, mild epistaxis, presence of minor hemoptysis is not a contraindication of giving anticoagulation. But there are conditions where you would not risk giving the anticoagulants because there are unacceptable high risk of bleeding, like recent surgery, hemorrhagic stroke, active bleeding, aortic dissection, intracranial or spinal tumors. You should avoid giving empiric anticoagulation, and you should expedite the diagnostic evaluation so that in these patients alternative strategies like IVC filters and embolectomy can be considered. So once you've given the empirical, you suspected pulmonary embolism, you've given the empiric coagulation, now side by side you are advising investigations. The common investigation which we order is the arterial blood gases, X-ray chest, electrocardiogram, baseline prothrombin time and partial thromboplastin time and platelet count, renal function test. You know, these tests like ABG, X-ray chest, electrocardiogram, these tests are neither sensitive nor specific for the diagnosis of pulmonary embolism, but they can help determine the prognosis once the diagnosis of pulmonary embolism has been made. Like for ABG, patient can present with a severe embolism, can have hypoxemia, widened alveolar arterial gradient, respiratory alkalosis, and the ABG could be normal in about 18 to 20% of the patient. Then ECG is another investigation which you order in many of these patients. 15 to 30% of ECG could be normal. Sinus tachycardia is the commonest abnormality you see in the ECG. Then most of the patients may have a non-specific ST and T wave changes. But classically, what has been described as S1Q3T3, not very commonly seen, but when it is seen, it is associated with poor prognosis. And there are other signs on the ECG which are associated with poor prognosis, like atrial arrhythmias, new onset right bundle branch block, inferior Q wave, precordial ST changes and T wave inversion. These are all associated with the poor prognosis. This is an ECG showing classical which you have been taught from the MBBS onwards, S1Q3T3, not seen in more than 25% of the patients. As you see, lead 1 there is a deep S wave, Q wave in lead 3, and there is a T wave inversion in the lead 3. This is called the S1Q3T3 associated with poor prognosis. Then chest X-ray is another investigation. This is not helpful to make a diagnosis most of the times. There are patients have a normal X-ray, almost 20 up to 20% patient may not have any abnormality. Atelectasis or non-specific pulmonary infiltrates are the commonest, 18 to 69%. Pleural effusion could be seen in certain individuals, cardiomegaly, elevated diaphragm, and the Humpton hump and Westermarck sign is also a wedge kind of opacity seen in the periphery of the lung. Humpton hump is also seen in some of the individuals, and Westermarck sign is also seen in some of the patients, which could suggest that this person could have pulmonary embolism. So after you have done the basic investigations, like you have done the ABG, you have done the X-ray chest, you have done the ECG, and then you have also done at the same time renal function test, the PT, PTT, platelet count, because these are the basic investigation which can help you. If you are sending a patient for imaging, then you require the renal function test also. And the coagulant profile helps you because it will help you whether you can give the anticoagulant safely or not. Then further investigations in these patients will depend on the index of suspicion of pulmonary thromboembolism, hemodynamic stability of the patient, availability of the test at the center, and sensitivity, specificity, and the positive predicted value of the test. All these things should go into your mind when you order a test to diagnose pulmonary embolism in your patient. If a patient has a high probability of pulmonary embolism and he can be easily shifted to a CT room, That means he is either on a very minimal vasopressor support or he is not on any vasopressor support. The diagnostic modality of choice is CT pulmonary angiography. And it is, as you can see on this slide, that there is a filling defect in the left pulmonary artery, and this is another CT which is also showing the filling defect in the left pulmonary artery. You don't need anything else to make a diagnosis of pulmonary embolism. The CT pulmonary angiography is very sensitive for the embolus which is located in the lobar and segmental artery, but it's not that sensitive and specific for subsegmental pulmonary embolism. But the mortality with subsegmental pulmonary embolism is also not that high. So it is the diagnostic modality of choice. And this was a study which was a large study which had shown almost 824 patients involved, and they showed the sensitivity of CT pulmonary angiography was 83% and specificity of 96%. And if it was combined with CT venography, it increased the sensitivity to 90% and specificity of 95%. So, if a person can easily go to the CT room, you should get a CT pulmonary angiography in a high probability case to diagnose pulmonary embolism. But if patient cannot go to the CT room, he is on a very high vasopressor support, his blood pressure is very low, and you consider it is unsafe to shift this patient to the CT room. So what you do is echocardiography, and preferably a transesophageal echocardiography. It can give you an indication that this person has a pulmonary embolism. A person who's got a large pulmonary embolus, you could see right ventricular enlargement or dysfunction, you could see a regional wall motion abnormality that will spare the right apex. You sometimes call it a McConnell sign. There could be flattening of IV septum because the right ventricle is enlarged, so it shifts the intraventricular septum, it gets flattening, it makes the left ventricular smaller. You could sometimes visualize the thrombus, sometimes the thrombus is present in the right ventricle, or you could see thrombus in the pulmonary artery. You could see there is no phasic collapse of IVC, tricuspid regurgitation, and you see the pulmonary pressure is high. So these are all indirect, and they do not diagnose, but in a suspected case, it can give you a clue and you can think that this person may have pulmonary embolism. So what I want to say is that no echocardiographic parameter has sufficient sensitivity to allow its use for diagnosis of PE in a stable patient. But if you have a patient of shock and you find the echocardiography is normal, you can probably rule out that shock is not because of pulmonary embolism. So that's the value of, and of course, in a suspected case where you find a lot of findings which were not there earlier, you could with reasonable accuracy make a diagnosis of pulmonary embolism. In addition to the echocardiography, the other test which you can do is a compression ultrasound. Single proximal compression ultrasound, if it is negative, can exclude venous thromboembolism in low and intermediate clinical probability. As you can see in this slide on the left side, you see ultrasound has been done, compression ultrasound. The first slide shows a normal artery and a vein. When you press it, a light pressure compresses the vein. In the third, you see when you press it, the vein is not getting pressed. So that's an indication that person has a thrombus in the vein. And it is a test nowadays many of the intensivists in the ICUs are doing, and very quickly it can give you a very important information. And if you are able to diagnose proximal DVT in a symptomatic patient or in an asymptomatic patient who has a contraindication for CT angiography, is sufficient to rule in a diagnosis of pulmonary embolism, and you can start treatment in that patient. So in a patient who is hemodynamically unstable, or he cannot be shifted to a CT room, or it is not available, then the transesophageal echo, or if a transesophageal echo is not available, then you can do a transthoracic echo along with compression ultrasound. With reasonable accuracy, you can get an idea about whether that person has a possibility of pulmonary embolism or not. Then the other test, which when we were in the earlier part of our practice, we used to do, is a VQ scan to diagnose pulmonary embolism. You give a radioactive label dye to these patients to do a ventilation and then a perfusion scan. And it gives you a report that it is a low probability scan, the intermediate probability scan, and a high probability scan. So, patient who has a low pre-test probability based on the Wells score and a normal low probability VQ scan, and they found that that patient has a less than 4% chances of pulmonary embolism. So, you could rule out pulmonary embolism. Similarly, a patient who had a high clinical pre-test probability, that means Wells score more than 6, and a high probability scan had a 96% chances of having a pulmonary embolism. But the problem with VQ scan is the large number of scans are indeterminate, and this could range from 6 to 88%. As you can see this, there is a ventilation scan, there is a full ventilation, but if you can see the left upper portion, there is no perfusion. So, probably this person has a pulmonary embolism. So, where do you do VQ scan in the current practice? It is done if there is a contraindication to the CT and there is a clinically you feel there is a high probability, like patient has a contrast allergy or patient has a chronic kidney disease and who is not on dialysis, morbid obese patients. In a pregnant lady, there has always been a controversy whether to do a CT pulmonary angiography or VQ scan in a pregnant. If you do a CT pulmonary angio, they say that the more exposure to the mother, less to the fetus. But now there is a consensus that VQ scan should be preferred in a pregnant lady to diagnose pulmonary embolism. And always remember that VQ scan is better if the chest X-ray is normal, because if the chest X-ray is normal, interpretation becomes very, very difficult. Then other test which sometime is ordered is the MRI. There are problems with the MRI. PIOPED 3 study had shown that it has an insufficient sensitivity and a high rate of technically inadequate images when it is used for the diagnosis of pulmonary embolism. MRPA or magnetic resonance pulmonary angiography for patients suspected of having pulmonary embolism in whom you could not do the CT pulmonary angiography or VQ scan, that is the only indication where you will do an MRPA, because you can't do a CT pulmonary angio and you can't do a VQ scan. In those patients, you could do a magnetic resonance imaging. Then a test which used to be considered gold standard is the contrast enhanced pulmonary angiography in a cath lab. As you can see in this, there is a filling defect in the upper lobe artery. There is no perfusion, and this test, after the availability of CT pulmonary angiography, is very, very rarely used. And it is only used if CT pulmonary angio, VQ scan, MR, they are not diagnostic. In those cases it is used, and it is used when you want to do a catheter based treatment, like you want to do a catheter based thrombolysis or thrombectomy in the cath lab, then you do a contrast enhanced pulmonary angiography or in what is in the DSA lab. The risk is that it has a mortality of less than 2%, and the only problem is that it gives a large load. But at present, this has totally been replaced with MDCT, CT pulmonary angiography, and rarely the VQ scan. Then there could be a patient who is hemodynamically stable and has low or medium probability of having pulmonary embolism. So, in these patients, you could do a D-dimer test, high sensitivity D-dimer, ELISA based test. If it is negative, it can rule out pulmonary embolism in the low and medium probability pulmonary embolism. If it is more than 500, then you have to do further test. Always remember that specificity of increased D-dimer is reduced in patient with cancer, pregnant lady, patient who are hospitalized, and elderly, because they can have a high D-dimer as it is. So, you have to be careful when interpreting the D-dimer in this group of patients. So, just to give you a flow chart, whatever so far we have studied, that whether a person has a high probability or likely pulmonary embolism, the choice is a CT pulmonary angiography. If it is positive, you will treat the patient as a pulmonary embolism. If it is negative, it excludes pulmonary embolism and you do not require to treatment. And if it is inconclusive, and or you could not do CT pulmonary angiography, then you could do additional testing like VQ scan, MR, or in rare cases contrast enhanced pulmonary angiography. If you confirm P, then you treat. If you exclude, then no treatment is required. Now suppose the patient is there, pulmonary embolism is unlikely, low or medium probability. You do a high sensitivity D-dimer assay. If it is more than 500, you go for CT pulmonary angiography. If it is less than 500, you exclude pulmonary embolism and no treatment is required. So to summarize, the diagnostic test will rule in the diagnosis of pulmonary embolism are the CT pulmonary angiography, high probability VQ scan, positive contrast enhanced pulmonary angiography, and magnetic resonance pulmonary angiography. They can rule in the diagnosis of pulmonary embolism. Similarly, normal or near normal VQ scan, negative MDCT angiography, negative CT angiography plus the proximal vein compression ultrasound of the leg, negative magnetic resonance pulmonary angiography, negative contrast enhanced pulmonary angiography, ELISA D-dimer less than 500 in low and medium probability rule out the diagnosis of pulmonary embolism. Now, the next very important step is to identify the risk of adverse outcome and how to triage a patient. So, if echo has not been done earlier, you should do an echo to find out whether there is any sign of right ventricular dysfunction, and TROP-I and BNP and pro-BNP. As I said earlier, if person has any one of these, right ventricular dilatation on the echocardiography or on CT, high BNP and change of EKGs which is suggested of RV strain, these are the sign of right ventricular dysfunction, and myocardial necrosis if the TROP-I and TROP-T are high. If person has any one of this helps you to how to triage a patient. Suppose a patient who is hemodynamically stable and has a pulmonary embolism, has a no right ventricular dysfunction, normal TROP-I level, he can be admitted in the ward. Similarly, patient with right ventricular dysfunction, injury, although he is hemodynamically stable, he should be admitted in the semi-ICU or HDU, and a person who is unstable with a right ventricular dysfunction or injury, he should be admitted in the ICU. Now, coming on to the treatment. The major or the specific treatment for pulmonary embolism is if you could do thrombolysis. The benefit of thrombolysis is that rapidly it can resolve the symptoms, reduces the RV damage, improves the exercise tolerance, and increases the probability of survival. The harm is that person can get bleeding and person can get a prolonged hospitalization. So, depending on the probability of pulmonary embolism above threshold in your patient, you treat them with thrombolysis. So, if a person has pulmonary embolism which is above threshold, you think the person has pulmonary embolism, he is hemodynamically stable and he does not have any signs of RV strain, only heparin anticoagulation should be given. Now, there is another patient who has a high chances of pulmonary embolism which you have diagnosed on a CT pulmonary angiography or any other test, and the patient has evidence of shock or respiratory failure. You have already given empiric anticoagulation in the form of unfractionated heparin. There is no contraindication or to fibrinolysis, then you should give these patient thrombolytic agent, and the choice most of the time is elliptilase 100 milligram over 2 hours. There could be another patient who is hemodynamically stable. No, but he has a signs of RV strains. He has a RV dysfunctions. He has a signs of myocardial necrosis. His BNP is high. His TROP-I is high, and he also does not have any contraindication to thrombolysis. Then this is another group of patients. Sometimes you can consider for thrombolysis, that is elliptilase 100 milligram over 2 hours. But the main indication for thrombolysis, hemodynamically unstable patient who does not have contraindication to thrombolysis, and you have proven a diagnosis of pulmonary embolism. But you must know what are the contraindication of thrombolysis, like absolute contraindications are prior intracranial hemorrhage, known structural cerebral vascular lesion, malignant intracranial neoplasm, ischemic stroke within the last 3 months, aortic dissection, active bleeding, He's got a significant closed head trauma in the last 3 months, and relative contraindications are severely or poorly controlled severe hypertension. Patient had a prolonged CPR more than 10 minutes, major surgery in less than 3 weeks, and recent internal bleeding, and he is pregnant, active peptic ulcer, and there is a current use of anticoagulants like warfarin, and you have INR which is more than 1.7. So, these are the contraindications where you should not thrombolize these patients. The choices of thrombolytic agents, most of the studies have been done with the streptokinase, urokinase and elliptilase. The best thrombolysis is with the streptokinase, but elliptilase has been shown result in a best outcome. So, that is why elliptilase is the choice. Now, the new drugs which are coming, lenaptilase, tenecteplase and retaplase, they are not very commonly used and not many studies have been done with this product. So, what to do after thrombolysis? If APTT is less than 80 seconds, you start heparin infusion without a bolus. If APTT is more than 80 seconds, you wait for 4 hours, repeat APTT. If it is less than 80 seconds, then again you start heparin infusion without a bolus. Then there could be a patient who has a contraindication to thrombolysis, or you did a thrombolysis which has failed. So, if a person has a contraindication to thrombolysis, but it is not an absolute contraindication to thrombolysis, then you can take that patient to a cath lab and you can do a catheter directed thrombolysis at the site of embolus. But if patient has an absolute contraindication to thrombolysis, then that patient you could do a percutaneous mechanical thrombectomy. There are various ways where they can take out the thrombus from the artery, and the patient is hemodynamically stability is restored in that patient. Then in a similar patient where you can't do catheter based thrombolysis or percutaneous thrombectomy, the surgical embolectomy is another choice in a patient who has a contraindications or where the thrombolysis has failed. It's technically simple, but logistically very complex, requires cardiac surgeon, cardiopulmonary bypass, but only one patient I have seen so far in my practice where surgical embolectomy was done in our country. But this is a modality which can be tried in a patient who has a contraindication for thrombolysis, in which the thrombectomy also failed or thrombectomy was not done. This is an alternative in that patient where you can do a surgical embolectomy. So, all other patient where you did not do thrombolysis and had pulmonary embolism, you will continue the empirical anticoagulation. But there could be patients in whom you cannot give empirical anticoagulation. So, IVC filter should be used. As you can see, there is an IVC filter lying below the renal artery in this patient. So, what are the indications for IVC filters? When a patient has contraindication to anticoagulation, or you started the low molecular weight heparin or unfractionated heparin, patient is still throwing pulmonary embolus, or patient is bleeding on anticoagulants. So, in these patients you could consider IVC filter, and most of the time the temporary or retrievable filter is put in these patients. Usually it is placed below the renal artery. So, that's you should always do a ultrasound or color Doppler to see that there is no thrombus in the renal vein, and if there is a thrombus in the renal vein, you should place suprarenal placement of the IVC catheter should be done. These IVC filters are non-permanent. They could be temporary or retrievable. Temporary are removed in few days, and retrievable filters should be also removed as soon as that patient can be started on anticoagulants. Then long term anticoagulation, you have to think in these patients who were started on heparin, and oral vitamin K antagonists have been used for many years and they have been choice. Out of these, warfarin has been used very often, and these should be initiated as soon as possible. Some people even start on the first day of starting the low molecular weight heparins. In a hemodynamically stable patient, they start on the first day when they started the low molecular weight heparin. And heparin is discontinued when INR is more than 2. And now there are novel oral anticoagulants which are available, like the rivaroxaban, dabigatran, apixaban. These are direct thrombin inhibitors or anti-10A, and they have found the risk of recurrences of pulmonary embolism are same as with vitamin K antagonist. And there are studies with dabigatran, the cover study which showed the recurrence rate under dabigatran as compared to the warfarin was almost same. Similarly, with rivaroxaban, Einstein study, apixaban, Amplify study, they all have shown that recurrent venous thromboembolism was not much different from the warfarin. And the new guidelines which have been published in 2016, they have gone on to say that you should prefer the novel anticoagulants like dabigatran, rivaroxaban, apixaban or edoxaban over vitamin K antagonist for a long-term therapy. So this is a change which we have been practicing, because the major reason for this is that recurrent venous thromboembolism is same as with warfarin. At the same time, you are not blocked with getting repeated INR because you don't require monitoring with these. And now lately there is availability of antidote for dabigatran. So I think we will have the antidote for all others, and these will be the product which we will be choosing for the long-term anticoagulation. So how long to give anticoagulants? If a person has a first episode of pulmonary embolism and there is a reversible risk factor, like for example, a patient who had a hip surgery is immobilized for last 5 days, or a knee surgery, or a patient who was on a ventilator for 5 days. So all these patients who do not have any other risk factor, 3 months is good enough. But in certain patients you cannot find the risk factor, and it is the first episode of pulmonary embolism, you give 6 to 12 months. If a person has irreversible risk factor, like patient has got a paraplegia, at least 6 to 12 months you give it. And some people have even gone on to suggest that you should give indefinite anticoagulation. But if person develops recurrent pulmonary embolism, then probably you should give lifelong anticoagulation to these patients. In pregnant lady, low molecular weight heparin is preferred over the oral anticoagulants, and just before the delivery you can change into unfractionated heparin. In patient who has a cancer and has a DVT of the leg or pulmonary embolism, so the treatment of choice would in these patients would be low molecular weight heparin rather than choosing the oral anticoagulants. And always the duration you have to individualize in these patients. Sometime if the malignant patient is getting a recurrent pulmonary embolism, you probably have to give a lifelong low molecular weight heparin to these patients. Then patient who has a heparin induced thrombocytopenia, then depending on the dysfunction of an organ, you could choose the drug. Like for renal efficiency, insufficiency, argatroban is the choice. For hepatic impairment, fondaparinux, and a patient who has got a both, then you can give argatroban or bivalirudin as a drug for a long-term treatment. A patient on oral anticoagulants, if develops pulmonary embolism or DVT, switch temporarily to the low molecular weight heparin, and before switching on, just see whether what dose he is taking, is he taking regularly or not, and always look for the underlying cancer. Then person who is already on low molecular weight heparin and still is having the recurrent pulmonary thromboembolism. So it is suggested in the new guidelines that you should increase by 1/4 to 1/3 the dose which has been recommended for that patients. So that is the first step you do in these patients. Now what you should do for a perioperative management. You know, this is another a person who's got a pulmonary embolism, he's on a long-term anticoagulants and he's going for surgery. So what are the recommendations? Suppose let's say patient is on warfarin. So you stop warfarin 5 days before the procedure, and the 2 days before the procedure you can start low molecular weight heparin in this patient, and 24 hours before the surgery you stop even the low molecular weight heparin, and after 24 hours after the surgery you could start the warfarin in this patient. Suppose patient is on dabigatran. These novel anticoagulants, it has been suggested how to go about when a patient is subjected for surgery. Like patient is on a dabigatran. So you stop 3 days before the procedure and then you resume dabigatran on day 2 or day 3 after the surgery. But the first 2 days after the surgery, you could give low molecular weight heparin to these patients. Similarly, for apixaban, you stop 2 days before the procedure, no bridging is required, just resume apixaban the day after the procedure, after at least 24 hours having elapsed after the surgery. Similarly, for rivaroxaban, you do not take the rivaroxaban on the day of surgery and resume the day after the surgery. So, I think one should know this because these questions are very commonly asked when to start the anticoagulants when a person has gone for surgery. Now, in the last few years, the aspirin is emerging as a drug to be given for a long term, particularly in unprovoked proximal DVT or pulmonary embolism. Patients who are stopping anticoagulants, like you said, 6 months and 6 months are over and do not have a contraindication to the aspirin, in the new guidelines which are published this year, long term aspirin over no aspirin to prevent the recurrent venous thromboembolism has been suggested. And this has been based on the meta-analysis of 11 trials where they have shown decreased recurrences rate of PE with aspirin after discontinuation of long term anticoagulation in an unprovoked pulmonary embolism. Compression stockings are really not recommended, but all these patients, as early as possible, you should try to mobilize these, because you are taking away the risk factor of DVT. So, people with a DVT that the thrombus may go and may cause pulmonary embolism is not recommended. So, as soon as you can mobilize patients of this, you should mobilize the patient at least to the chair. So, what are the complications? Of course, the early complications of pulmonary embolism is the person can get a recurrent pulmonary embolism. The late complication in a patient where you've treated nicely is the chronic pulmonary thromboembolic pulmonary hypertension, which develops in first 2 years. Up to 9.1% of patients who had pulmonary embolism can have chronic pulmonary thromboembolic pulmonary hypertension, and it develops within first 2 years. So, you should have a repeat echo in these patients if they have symptoms or otherwise to rule out these complications. So, just to summarize, the pulmonary embolism is a dreaded disease, a common disease. One has to keep in mind it is a preventable cause of hospital death. You should suspect when patient has a sudden onset worsening dyspnea, hypotension or chest pain. Mortality is 30%, and with a quick treatment you can reduce to 2.5% by appropriate management. Massive pulmonary embolism is life threatening, and any patient after you've done the initial stabilization, if patient can be shifted to the CT room, MD-CT, CT pulmonary angiography is the investigation of choice. If patient cannot be shifted, then transesophageal or the 2D echo and a compression ultrasound should be done to make a diagnosis of pulmonary embolism. Give empirical heparin anticoagulation to all cases of suspected pulmonary embolism pending investigation if there is no contraindication, and thrombolysis is the very specific treatment, particularly for patients who are hemodynamically unstable and have a proven pulmonary embolism, patient of submassive pulmonary embolism which have a sign of right ventricular dysfunction and myocardial necrosis, and the other indication is pulseless electrical activity during CPR. This is another indication where the thrombolysis can be given. If you see on an echo that there is a thrombus, this can be given and it can improve the outcome in this patient. Immediate anticoagulation is the treatment of choice in stable patient. Low molecular weight heparin is preferred over the IV unfractionated heparin. You should prefer the novel or the newer anticoagulants over the vitamin K antagonist for the long term therapy as per the new guidelines which have been published in 2016. In cancer patient or a pregnant lady, you prefer low molecular weight heparin for a long term over the oral anticoagulants, and you have to individualize the duration of treatment of pulmonary embolism to get a good outcome. Thank you.